Hello, everyone. Thank you so much for joining. We are going to wait a few more minutes as we have more people join the call, but we are really looking forward to this discussion about the National Academies of Science, Engineering, and Medicine's newborn screening report. I will repeat this again, but this session is being recorded and will be uploaded on the Expecting Health and the Genetic Alliance YouTube pages in the upcoming weeks. Great. We are at 12:01 with a filling virtual room so we can get started. I'm Natasha Bonhomme, founder of Expecting Health and Chief Strategy Officer at Genetic Alliance. And I am really excited to welcome you all to this session, our first of three, looking at the newborn screening, a vision for sustaining and advancing excellence, which is the consensus report that the National Academies of Science, Engineering, and Medicine released earlier this year. That report has a focus on recommendations to strengthen newborn screening as an essential public health service. Genetic Alliance is hosting a three-part webinar series, this being the first, to highlight the key findings and also to invite discussion amongst interested stakeholders across the newborn screening ecosystem. So before we dive in, some logistics. This call is being recorded, so we will have those recordings available to you via the Expecting Health and the Genetic Alliance YouTube pages in the upcoming weeks. We will start this session with a discussion from Dr. Don Bailey, and then we will go into our respondents speaking to that. We will have one or two questions, and then we will open it up to the participants on the line to discuss further. If you have questions, you can use the chat feature. So without further ado, I hear a little bit of noise. So before we go further with this session, as a reminder, this is the first of three sessions, this one focusing on the report and the response from the rare disease community. Later in August, we will have one session focused on newborn screening as a high-quality public health service for all. And then we will also have a session about preparing for the future of public health newborn screening. So we will start today with Dr. Don Bailey, who is a distinguished fellow at RTI International and is a member of RTI's Genetics and Translational Research Center. He's a senior advisor for Early Check, which is a statewide research project which focuses on helping prepare newborn screening for new conditions and new technologies, with a current focus on genome sequencing. He served as a voting member on the Secretary's Advisory Committee on Heritable Disorders in Newborns and Children. And what he will be speaking towards is that he was also appointed as a member of the National Academies of Science, Engineering, and Medicine's Committee on Newborn Screening, the current landscape and future directions. So Don, if you'd like to move forward.
Great. Can you see my screen okay?
Yes.
Well, thank you, Natasha, and thanks everybody for joining us today. It's a real privilege to have served on this committee, and so my job in the next 15 minutes or so is to provide a big picture overview of what the committee did and what our recommendations are. Of course, I would encourage everyone to read both the executive summary and the full report to get background and a better understanding of each of the recommendations. Okay. All right, my slide is not advancing, so I'm going to just stop for a minute. Sorry about that. Okay. So the report was something, our work was came from a request from the U.S. Department of Health and Human Services, which asked the National Academy of Sciences then to convene a committee. We had three really big activities. One is to take a look at the current landscape of newborn screening in the United States. So what's happening and how's it going? What are the challenges and opportunities that exist? And then to build on that, to recommend options to strengthen what we consider a very strong and important public health newborn screening program in the short term, but also to establish a vision for the future of newborn screening. Because there's a lot going on in the newborn screening world right now, and we just need to be prepared for it as we embrace the next 5 to 10 years. So the committee there are 14 members on the committee. We'll have names and photos of the members at the end of the presentation. Really fascinating and interesting group to be a part of. It was a very diverse group in terms of expertise, and ranging from newborn screening, public health, lived experiences, and bioethicists, technology specialists, healthcare system specialists, health economists, and clinical clinicians. And so I would say that there within the committee was a range of experience and familiarity with newborn screening. And that was actually a great thing because it kept forcing us all to think about, okay, what are the core features of screening and how do we explain it to people who might not be fully engaged in that particular program? So over about a year, we reviewed literature, we held public workshops and webinars, we received input from over 600 people across newborn screening through public engagement activities and multiple meetings, both virtual and in person. So just to make sure, I think most people on the call would already know this, but just want to do a level set of what are we talking about here. So newborn screening is a public health program that identifies babies who are at risk for serious but treatable conditions. These are babies whose condition is not obvious at birth. If it was obvious at birth, you wouldn't need to do newborn screening. But these are conditions that need early treatment before symptoms appear to ensure a maximum benefit. So almost every baby in the United States is screened through newborn screening programs. Close to 3.6 million babies, and really over 98% are screened. An amazing statistic, really wonderful example of public health success is that over 7,000 babies are identified for timely intervention and treatment each year. So newborn screening is implemented through state and territorial public health programs. It's not a federal responsibility to run newborn screening. It's a state and territorial responsibility, but it's supported by a wide range of partners. Certainly the federal government plays a large role in various aspects of newborn screening. Advocacy groups play essential roles. And we also see clinicians, academia, industry, and others. So it's really a village that supports an overall public health newborn screening program. So why was the committee formed? What are some of the challenges that we were trying to address? I won't read each of them in detail, but just to say that first of all, this whole, as you know, with the Secretary's Advisory Committee and the Recommended Uniform Screening Panel, there has been a condition by condition review been very important to determine whether benefit from screening will occur. But with an era of rapid discovery in genetics, genomics, and in more effective treatments, that these things are moving much faster than what has been happening in terms of the condition by condition review process. So we need to figure out ways to address that problem. The second issue is how to strengthen newborn screening programs that vary across different states. We want to take a look at new screening technologies, and especially whether there's some ethical, local, or social or legal issues about how those technologies are used. I want to make sure we take into consideration privacy and consent concerns. Thinking about how we can improve delivery when there aren't any systems for data collection and integration at the level that we really need. And then finally clarifying what can public health newborn screening do and what it can't do and shouldn't do, and what complementary investment is needed to support rare disease communities. So before I make the recommendation, summarize the recommendation, just say several key messages. One, the committee believes, and I think everybody on the call, that newborn screening is an essential public health service. And aligning this mission entails a focus on conditions that are serious, urgent, and have therapeutic interventions. We need to be clear about what we're looking for and how we're doing it. We know and we recognize that there's variability across states, and some of much of it is appropriate because of state needs and resources and priorities, but it can also result in some variability in who gets screened and for what conditions. We want to try to minimize variability as much as we can. Strengthen the network of programs to achieve excellence is going to require financial and non-financial support. We can't just ask people to do it, and of course it'll immediately be done. This is going to require national leadership and coordination. I'll speak about that in a moment. Screening has to include an engagement with families, screening policy, and also setting clear laws and policies about storage and use of residual dried blood spots. And finally, we feel that a national plan for research is essential if the evidence that's needed for newborn screening exists. So there are nine priorities that are part of the report. And I won't read these at the moment because I'll go through them briefly in just a moment, except to say that we've lumped those into four broad categories, and I'll go through each one of those now. So the first category is to lead with an aligned mission. So how do we get everybody together to think about and do the things that need to be done in a coordinated fashion? The first recommendation is to establish national leadership and set priorities. Under that, we are clearly saying that HHS should provide a unified leadership and accountability and a coordination across different agencies. So as you know, there are many different federal agencies now that have a responsibility for some aspect of newborn screening. Those activities need to be coordinated and integrated in stronger ways. And to do that is not going to be simple. It's going to take some strategic planning. And so we're recommending that HHS actually establish a 10-year strategic plan to do that quickly, based on this report recommendations, and then begin to implement the recommendations in the context of that plan. In doing so, I feel very strongly that multi-stakeholder and rights holder input needs to be thoughtfully considered and included in policy decisions. And so we're recommending that HHS establish a multi-stakeholder rights holder advisory body that would provide input into national leadership for the first recommendation. So what was the current advisory committee for heritable disorders in newborns and children provided a really important set of activities and recommendations regarding newborn screening. But we feel like there's also a need for an advisory body that has a broader and a more comprehensive role in shaping newborn screening policy at the national and state level. Just a few quotes here that will exemplify some things that we heard from different people. So here's one parent who says, valid newborn screening test and a valid treatment might exist for a disease, but it takes a long time, the better part of a decade, to get it added to the recommended uniform screening panel. And it taxes the advocacy organizations who can least afford to spend their valuable time and resources on this. So we did recommend that optimizing decision making on decisions included in newborn screening is going to be essential. So we need some kind of focused mechanism to provide advice on the RUSP, and proactively assess the conditions that ought to be included, and periodically reassess evidence as new evidence emerges. But to do that, we're going to have expanded scientific and technical capability for reviewing evidence. It's just simply too long, and insufficient resources have been put into reviewing the multiple disorders that are certainly coming forward as in nomination for newborn screening. And along with that, of course, once there are federal recommendations that are being made, state and territorial newborn screening programs should have a mechanism to consider implementation within a designated timeline. Just want to make a quick note, side note, to say that our recommendations in the report was pretty much done before the major changes that have been happening at the federal level, including the disbandment of the Advisory Committee on Heritable Disorders in Newborns and Children. So we focused our recommendations on as broad a level as we can, and we feel like they're as valid now as they were when we first wrote them. Another concern the parents raise is the lack of uniformity from state to state. Some families living in one state might have their child identified, whereas if they lived in another state, the child would not have been identified. So we need to advance program excellence. That's the second broad category. So supporting local newborn screening programs. We need to have data. It needs to be a uniform performance improvement system so that at a national level, we have big picture data, and at the state level, we can see how states fit into the overall national picture in terms of successful screening. Partly, but the data itself are not going to be useful alone. So to amplify newborn screening program excellence, there need to be some shared resources. And so this could be centers of excellence. It could be a variety of different technical assistance programs, but there need to be resources to help states implement and provide the infrastructure they need to move as quickly as possible, given their state and local context. We spent a lot of time talking about public trust. Newborn screening rests on the assumption that that this is an important public health activity that's warranted because of urgency. But oftentimes we heard that the public is not as aware of newborn screening as everybody would like, and that different professionals may not be aware of newborn screening as much as they should be, and newborn screening education and awareness is not at a level that we want. We're recommending that professional associations all issue recommendations for communication about newborn screening with pregnant patients, with parents, and caregivers. And then importantly, in terms of the public trust, we said that there need to be standards for the retention, sharing, and use of newborn dried blood spots and derived data. Now, the federal government doesn't have the authority to establish standards that states are required to follow. So this is going to be up to the state legislatures to do this. And so we recommend strongly that state legislatures set policies and laws to protect the retention of dried blood spots for the important activities, set transparent practices and policies for what those uses and activities are. Of course, to allow parents and then individuals to request blood spot destruction when appropriate. And then finally, to prohibit the sharing or use of residual dried blood spots to conduct criminal, civil, or administrative investigations. There for the future, many of us have talked about this chicken and egg dilemma that public health newborn screening needs evidence for benefit, but oftentimes you can't get this benefit, this evidence without actually doing the screening. We need to expand our capacity to do newborn screening research, and it needs to be done, we feel, at a national level with more coordination of networks of programs that address systems level research priorities in a coordinated and nimble manner rather than one-off kinds of activities. And then finally, to promote the responsible application of technologies to newborn screening, this is specifically addressed towards genome sequencing as a challenge and both a challenge and an opportunity. The opportunity we feel is great, but the needs to really understand the technical, ethical, and implementation questions are essential. So just to conclude by saying that everyone on this call and all the people who are involved in newborn screening have a role in helping to make this happen and to implement the recommendations of the report. Again, I would encourage you to go to the National Academy's website and download the full report. And just to finally say, this is a great committee. I really enjoyed working on it. Again, very committed and individuals who really understood various aspects of the newborn screening system and are really trying to work to make it better. Thanks a lot. This is the information for how you access the report. And I know Natasha said that'll be available on the Genetic Alliance and Expecting Health websites. That's it for me.
Great. Thank you so much, Dawn. We will now move to our respondents, our panelists. And so I will do a quick introduction of all three, and then they will take it away with their 5-minute responses. So first, we will start with Dr. Titilope Fasipe, who is the co-director of the Sickle Cell and Thalassemia Program at Texas Children's Hospital and is assistant professor of pediatrics in hematology oncology at Baylor College of Medicine. She's passionate about public health strategies and public health strategies that target the psychosocial barriers and health complications of individuals with sickle cell disease. She has the unique perspective of relating to and understanding the needs for education, community awareness, support, and medical care, as she is a pediatric hematologist as well as an individual with sickle cell disease. We will then have Lisa Brackbill, who is a wife, mother, author, and advocate. Her dedication to newborn screening advocacy began in 2015 after her daughter, Victoria, was diagnosed with Krabbe disease. Lisa's 5 years of efforts led to reform of the Pennsylvania newborn screening program. In addition to her state-based work, she serves on the board of directors for Krabbe Connect and is the associate director of advocacy for patient advocacy strategies. And then we will have Annie Kennedy, who is Chief of Policy, Advocacy, and Patient Engagement for EveryLife Foundation for Rare Disease, will then speak. Annie is a veteran in the rare disease patient-focused drug development movement and joined EveryLife Foundation in 2018, where she's led numerous community-driven evidence development efforts, including the National Economic Burden for Rare Disease Study, the Newborn Screening Modernization Roundtable Series, and the Cost of Delayed Diagnosis in Rare Disease, which is a health economic study. Annie's community roles have included serving on the board of directors for Cure SMA, the National Duchenne Newborn Screening Steering Committee, and as a member of the NIH National Center for Advancing Translational Sciences, also known as NCATS Advisory Committee. So a very knowledgeable group. So I will turn it over to you all for your 5-minute responses.
Thank you so much, Natasha. It's a privilege to be here. It was lovely to see Dr. Bailey also again. It's a reunion as well. And I wanted to say thank you to the Genetic Alliance for hosting this 3-part webinar series to really educate our various communities and spaces and to continue the great work they do in improving outcomes in health for individuals with rare diseases and genetic diseases. So as Natasha said in my introduction, I'm a pediatric hematologist, and I consider myself an end user of newborn screening. A hospital and a pediatrician will send the newborn screening samples, of course, to the state labs, and then I eventually get a referral whenever the tests come positive for a hemoglobin disorder. And there's various types of hemoglobin disorders. The most common is sickle cell disease. And I'll also comment that in that end user space, we also get individuals that do not have diseases, that have carrier statuses of various types because of their hemoglobin diagnoses. But then on the other end, I'm a very vested person in newborn screening from a personal standpoint because I was born with sickle cell disease. And I was born in a country that did not have universal screening for sickle cell disease in Nigeria, and still doesn't. It's something that various global entities are working on. And so by the time I came to the United States of America, there was also not universal screening for sickle cell disease. But by 2006, it became universal. And since then, every child who does have sickle cell disease or a hemoglobin disorder is detected on the newborn screening. And this, of course, allows them to get into care in a timely fashion. And so for those two reasons, I was quite honored to be invited to participate on the newborn screening, the National Academy of Sciences, Engineering, and Medicine Newborn Screening Committee, along with Dr. Bailey and the others that he showed. I also wanted you to know there were a couple of other members of our committee that also had personal stories related to newborn screening, including one of our members who is a mother whose children have a rare disease, and then some of our other members that have carrier statuses. So when I reflect on this report, there was first this awe of the magnitude of capturing various spaces in what we now see as a system for newborn screening. You know, I was so like naive in my, oh, okay, I get a baby in the clinic and we can talk about their newborn screen and go on from there, confirm their diagnoses. I didn't fully respect until this experience the magnitude of all the individuals that are coming into play, including the public health laboratories and also the various scientific innovators who are behind the technologies behind this. And then one of the most heartbreaking for me was hearing the perspective of impacted families, of course. Not only was it something that resonated with me, thinking about how my parents' own journey with me, but just when I see families in my clinic and their hopes and dreams for their precious baby kind of come to this crushing halt when they get a diagnosis. But then there was this voice of several in the rare disease space where you have a child who has a disease that's not reflected on the newborn screening panel. And so hearing from all of those various spaces, it was quite humbling and it was quite enlightening for the entire committee. And I know we're going to have some time later to discuss in the question and answer portion, but I wanted to reiterate something that Dr. Bailey said. We really wanted to capture all of these spaces and not just the ones who maybe had much more experience in advocating, but even those that were, you know, your regular general public. And so we were able to hold several live sessions and also receive a survey. And collectively, we heard from over 600 people from various spaces. And we were grateful for each of those. And I'm sure some of you are in this call today as well. So with that, I'm going to stop and allow our next presenters to discuss and look forward to the remaining discussion.
Thank you. Lisa?
Thank you so much for inviting me to be here today. As I was thinking about what I wanted to say, more than anything today, I just wanted to convey a sense of urgency. I've been in the newborn screening space for over 10 years. And as Natasha said in my intro, my journey began not long after my daughter was diagnosed symptomatically with Krabbe disease. On her diagnosis day, we were told three things. We were told that our 6-month-old daughter was dying, that there was nothing that we could do, but that if we had caught it at birth, we could have treated it. And those 12 words still haunt me today. And that's what fuels my passion to improve and expand newborn screening, to save other parents from the horrific loss that we have experienced. In these last 10 years, I've been part of the rare disease community's efforts to see incremental change happen. We worked so hard to see modest but meaningful change, and we had actually made great progress in that time. So when this study was announced, we as a rare disease community were already collectively working to improve the RUSP process, among other things. And as someone who has now walked alongside 2 different disease communities in the RUSP process, I certainly saw the brokenness of the system firsthand. And I actually spoke in public comment about the flaws that I observed a few times. At first, the ACHDNC seemed to dismiss our concerns. However, after so many of us spoke up, we also did start to see a willingness from the committee to make meaningful changes in the year prior to its dissolution. We were cautiously optimistic that better things were ahead, and we were working with a broken system, but at least we had one to work with. As we all know, before this report was released, the ACHDNC was dissolved, leaving us with no pathway and a seeming lack of urgency to put anything in its place. And this has been devastating to the advocacy community. Many of us entered this space because of our own grief and loss, and we desperately understand the need to add more conditions more quickly in more states so that we have increased uniformity, because right now zip codes do determine life or death if you're born with one of these rare diseases. We want an evidence-based process to continue to exist, because we as parent advocates are the ones who are going state by state, trying to convince newborn screening advisory boards that our condition deserves to be added. We are the ones on the ground making decision makers aware of the changes that need to be made. So parent advocates feel the loss of this committee and the oversight from HRSA deeply. So now, given this landscape, my hope is that this report is going to help guide decision makers, but also instill within them a sense of urgency for creating a new pathway for the RUSP and newborn screening. We cannot wait years to put something in place. I know Donna mentioned that they gave a 10-year proposed timeline. Time is life or death for these babies, and that's something that weighs on me daily in the work that I do. We need a pathway now, whether that means restoring what we had and then working to improve it, or allowing us to be part of creating something new. So maybe the timing of the release of this report is actually perfect, because none of us knew how 2025 was going to play out. And we certainly did not anticipate such great losses for the rare disease community. So looking forward, I believe that this report is exactly what's needed for our future as a newborn screening community. It's something we can hand to decision makers, and it can educate them, empower them, and also guide them with exactly what we need. It's an excellent guide for anyone wanting to learn more about the newborn screening system and why it matters, and what we can do now that our pathway has been taken away from us. We have an opportunity to build something better than what we had, but I do fear that it's going to take too long. We have new treatments being approved each year that rely on newborn screening for access. We must keep pace with science and technology, or parents who otherwise would have been able to save their child's life, like us, will be denied access. The Krabbe disease community has the advantage of already being on the RUSP. We currently have 13 states screening, with 2 more starting in just a week or 2, and several more that are working toward implementation the next year. But there are so many other disease communities that are now left without that opportunity. Their work will be harder, their burden will be harder, and the already overburdened and understaffed state programs will be increased as well, because now they will have to conduct their own evidence reviews. As overwhelming as the past 6 months have been, I have seen the rare disease community overcome huge hurdles, and I know that we will prevail here too. But we need to ensure that our stories continue to be told to those who now hold the future of newborn screening in their hands, to provide this report to as many decision makers as possible so that they can see the evidence behind our stories. We cannot expect them to care or to feel urgency about newborn screening if they don't even know what it is. I know that I didn't know what newborn screening was until I found out the impact it could have had for our daughter and our family. So we must continue to meet with them, to educate them, do whatever we can to ensure that they understand why this matters. So using this report, we can do what we do best as advocates, which is teach. We can empower them to make a difference. We can speak the administration's language about a healthier America, curing chronic disease, saving babies and families. We can reuse their language and use this report to help us help them make that connection between newborn screening and their goals as an administration. So sharing this report is actually something that we should all be doing with as many of our legislators as possible. In closing, this report, I believe, provides us a compass in this time of uncertainty when our roadmap is very much under construction. And so I hope that Congress will take it seriously and understand that the lives of children born with rare treatable conditions depend on them. Thank you.
Great. Thank you so much, Lisa. And Annie, your comments.
So I just want to start by thanking Genetic Alliance for bringing us all together here today. And most especially, I want to thank the National Academies for convening this study. We at the EveryLife Foundation had been working as a part of a broader coalition for a very long time on the reauthorization of the Newborn Screening Saves Lives Act, which we're currently actually working on again. And this concept for this study had been a part of that legislation. And as we were hitting some hurdles in Congress with getting that legislation moved forward, we determined as a community and as coalitions that we couldn't wait for this study to be done, that the urgency across the community, as you've heard articulated so well by my fellow panelists, couldn't wait for another 4 years, or what turned out to be another 6 years, that we needed to pull this out and try another mechanism to move it forward. So as communities, we moved this forward through another congressional vehicle. We moved it forward through appropriations requests. And we're just really grateful, first of all, we should say, to everybody who took time to serve on this committee. So thank you, Dr. Bailey, for representing everybody here today. We know that it takes hours, weeks out of your regularly chaotic professional schedules to serve on committees like this. So we're just really grateful for the time everybody took. And we're grateful to the committee for really surveying the landscape and taking time to incorporate broad stakeholder input, the time that we were all able to come forward and present our perspectives and then be a part of focus groups. So there was a really comprehensive look across the community that went into this report. And that was summarized really nicely in bringing forward the 9 recommendations. The call for this really spoke to the fact, as Lisa just talked about, that really the pace of opportunity for therapeutic delivery across our communities is outpacing our existing infrastructure and ability to support systematic assessment and care delivery. So in other words, as rare disease communities, we know that we have life-saving therapies sitting on the shelf and babies who are not receiving them in time to save their lives or improve their outcomes. And since this report has come out, that situation has not improved. And so these recommendations really represent an opportunity to save lives. And so we're really grateful to the Academy for pulling forward these recommendations. Some of these recommendations have things that are actionable. So I just took a moment to scroll through and look at who's here. And there are many of us who work together in other coalitions. And we're right now looking at how do we make sure that the funding and resources exist to implement some of these concepts. Some of these recommendations were to actually do more work in some of these spaces to really understand how we pull whole genome sequencing and other innovation forward. But I think the call that we would make right now is that the time is really now to be doing these things, that the science and opportunity is now to be doing these things, and that we should all be really working collectively together to figure out how to do that. I know we're going to get to a Q&A, so I don't want to cut off Natasha's opportunity for questions, but there are some real opportunities. There are actually programs named in these recommendations that are at risk right now, and that we as communities need to really come together to make sure that these entities will still be in existence and be resourced to do the life-saving work that our communities deserve. So I'll stop there, and then when we get to Q&A, I'll be able to chime in further.
Great. Thank you so much to all 3 of you for the responses. So if you would like to ask a question, please use the React button at the bottom and raise your hand, and we will just go in that order. And as people queue up, one question I have for you all that you can take in whichever direction you would like is, there are all of these different key points that were presented in the report, which is a lot. There's a lot there to work from. And we know that no one group can do all of this. So just wanting to get your take on what are some potentially new partnerships that would be needed to really move forward the vision of this report from your stance. And whoever wants to chime in on that can do that as we have our participants raise their hand to ask questions.
Lean, I can just start. I'll start since I'm not muted, but I'm not the only one who should be speaking. I mean, there were a number of the recommendations, but I'll just start with recommendation number 3, I think is one that's incredibly important to us. So that one really speaks to, and Dr. Bailey can go into more detail since he served in the committee, but that one really speaks to how conditions are added to the recommended uniform screening panel. That from our perspective, there were a couple of recommendations within that recommendation that talked to increasing the number of scientific and technical experts that are involved in evidence review, designing a dedicated or specialized committee or mechanism whose focus would be on providing advice to the RUSP. Since that time, we've obviously had really seismic shifts in what's happening around the advisory committee and that infrastructure, which, I'm a glass half full type of person. I think that also provides us with opportunities to think about how we reinvent that. There were recommendations around infrastructure above the infrastructure that provides some technical advice and expertise and consistency around the evidence reviews. But to me, this is an opportunity for communities to come together. It's also an opportunity to ensure that experts in those conditions that are being evaluated are at the table, including patient community experts, clinical experts, scientific experts, to inform the decisions and the discussions and aren't in the audience for those discussions. And I think that needs to be one of the key considerations that's made as we think about what that infrastructure is going forward.
Something that came to mind is really involving state programs more, but that also is going to involve advocates. So for example, in Pennsylvania, our program was limited with what they could add because of funding, because they had to go to the legislature every time they wanted to add a condition. So I changed that. That's obviously a very nonchalant way to describe 5 years of work, but the newborn screening programs and labs can't advocate, they can't lobby. That's us. But if we don't know what the needs are to help them implement these conditions while we're waiting for a federal solution, then we can't help. So I think that while we wait, in the meantime, we as advocates need to be reaching out to our states and say, what do you need? Like, how can we help you move things forward? Because we don't know how long it's going to be before we have a new solution.
Thank you for that. And I think that particular piece of reaching out and building partnerships within states is so critical. We've heard time and time again where people have, even just gotten into a room, done a lab tour, and actually build real relationships, how that has led to better understanding both for patient advocates and for state public health officials in terms of really understanding what happens after a test is run and after you get the diagnosis, right? For so many families, there's the journey to diagnosis, but then there's a whole other journey after diagnosis. And it's important that, the whole system appreciates all those pieces. I see Cheryl Harris, you have your hand up.
Hi, thank you, Natasha. I'm Cheryl Harris from the Louisiana Newborn Screening Program. I was just wondering what role, if any, CMS played in creating the report. For us, when we're considering adding additions, we look at CMS's role, and particularly with reimbursing our program for screens so that that helps generate income for our program to continue screening. Thank you.
Um, I'll try to answer that, but if there's anybody from the National Academy that could also speak up. But we tried not to focus or privilege participation from a particular agency, but really tried to get input from a variety of different sources. And so even in our recommendations about national leadership, we didn't really say, well, CMS needs to do this, CDC needs to do this, NIH needs to do that, because these are all fluid situations, and obviously things are changing pretty rapidly right now. So we tried to focus our work at a big picture level, and Cheryl, and so the emphasis on CMS was not any greater or less, I guess, than any other aspect of federal government.
And just to, oh, and it looks like.
Hey,
Emily.
I'm Emily. I was a study director for the city. I just wanted to pop in. I heard I come down and say currently the federal partners for newborn screening, at least as they were built, kind of as before there was more shifting, were HRSA, CDC, ARC, NIH, and I'm missing one, but not CMS. And so the report does acknowledge that as we think about the federal landscape and bringing in all these different partners, that CMS needs more of a seat at the table for all the kinds of reasons that you were just discussing, Cheryl. And my apologies to the fifth federal agency that has just popped out of my head.
Can I, Cheryl, this is Annie. I actually love your question because I think it speaks also to one of the things that Don had mentioned in his presentation that helps speak to the need for this assessment across the ecosystem of what was happening and sort of some of the pressures on the newborn screening ecosystem, is that one of the things that the rare disease community, but really all communities talk about, is that a lot of, I like to refer to as the rocks in the backpacks of condition addition, fall to patient communities and patient organizations to help coordinate the evidence generation that brings nomination packages before the advisory committee. But a part of that work that isn't even a part of the nomination package, actually, in the evidence review, is oftentimes those patient advocacy organizations also have to nominate ICD codes and do that work so far upstream because those conditions are so rare that we can't even collect the health economic data. We can't even make sure that they're being tracked in the healthcare system. And so that your question really speaks to there's so much happening on sort of the bookends of the ecosystem also around newborn screening that, I think we've typically looked at newborn screening as this moment in time. And one of the things that is talked about within the recommendations is thinking about how we look at newborn screening as an ongoing system, and that the touches and the points of contact for the community have to be ongoing, that this is a system. This is a system of follow-up interaction. But you're actually touching on something even further out, and it starts long before an individual is screened and continues long after that family learns that their child has a condition. So I just want to sort of call that out, that that's all a part of this process, and we're not resourcing that either. And I thank you for raising that, because that's something that we need to be thinking about.
Great, thank you. I want to chime in that the fifth agency was FDA that Emily was speaking about. And there is a question in the chat that I'll bring up now. Understanding that there's a need to prioritize conditions that are treatable, but what is the appetite for involving rare conditions who do not have a treatment? Identification of them at birth could mean that families can make choices take action about risk associated with having a second child with the condition, especially important when the condition shortens life. And I will add another layer to that for you all to respond to, is taking that question and putting it within the context of, more and more discussion around whole genome sequencing and what that's supposed to deliver at some point, whether parallel to a newborn screening public health program or embedded within it. So I turn that over to you all.
Well, I'll start. So really, thanks, Susie, for your comment and question. And it really reflects a large and sometimes challenging dilemma for public health. I think everybody agrees that it's important to identify as early as possible conditions that are treatable or actionable, and things that could be done, that need to be done very early in life. And that's really been the core mission of public health newborn screening, and it's in part why screening can be done really, for the most part, without a fully informed process. The more you get beyond that core mission, there's more variability, first of all, in people's perceptions or perspectives on whether that's a good idea or not. And secondly, it evokes a bigger need for asking parents ahead of time, what information would you like? Because not everybody wants all kinds of information. So you asked a really important question, Natasha. You're right. In the context of whole genome sequencing, if that ever becomes a part of the core methodology that newborn screening programs use, then there's going to be a lot of questions about what results to return and what not to return, and what's the responsibility of public health newborn screening programs when you do gather data of that magnitude. So it's one of the things that we know needs to be addressed and through research and through stakeholder engagement.
Yeah, and I'd like to add, I agree. I love this question because it keeps on reminding me that our innovation and technology capacity sometimes outpaces our societal infrastructure and systems. And I feel newborn screening is an example of this. We all discussed this point intensely during our committee sessions. And one of the things we wanted to emphasize the most is, I think you used the word appetite, and I think a couple of other people may have used that word. We want to make sure people understand that we need to be mindful of these technologies and how to even support infrastructure to make them do the things we hope they can do. So we already saw ourselves as a future outdated recommendation because we want a day where you have the technology and we already have a process in place to utilize it in an effective way. That's why we didn't have a 30-year plan or a 40-year plan. We want this to already have a new standard in the short term. So we felt strongly about adding that research component to not just strengthen the innovation, but to get input from various expert groups. And expert in this case includes advocates, expert includes researchers and scientists, and it includes public health officials. So it's not just an ivory tower of researchers talking to themselves. It's something that has input from various spaces, including the federal government. This other comment was raised about who is this report for? Who are we talking to? And though the words HHS or Health and Human Services appears frequently in the recommendations, this is truly a report for all of the components of the ecosystem. And I appreciate the comments about holding our states to task. I was really excited that I got to present this at our state newborn screening advisory committee, and I encourage everyone to do the same. Let your state see this as a role for them to step up as well, and a space for advocates to intersect with the conversations.
Great, thank you. One question that came up in the registration portion when people were signing up was talking about the Advisory Committee on Heritable Disorders in Newborns and Children and what happens now that that has been eliminated. And, it would be great if you all could share about any efforts, formal or informal, that are underway to really be able to maintain that momentum of both evidence review and also the national dialogue on screening, that the advisory committee at least held a place for that to happen.
I mean, I can start and say that we are thinking of this as there's sort of a short term, a midterm, and a long term approach to what's happening here. In the short term, as many are probably aware, there were 2 conditions that had been under review, and their reviews were near complete. And they really got caught in sort of this swirl of activity. They were due to be have their evidence reviews presented at the meeting that would have been about a week or 2 after the advisory committee, the federal advisory committee was eliminated. So in the short term, we are working with those 2 communities on their respective advocacy efforts to ensure that those reviews be completed. And we've been working with HRSA also to ensure that those reviews are completed and move forward to the secretary, so that because those had already been funded by HRSA, that they have a path forward for evidence review and recommendation to the secretary. However, there are many conditions and a few that were very close behind that need a path forward. And so in the midterm, we are also working with communities and with the secretary and with HRSA. And our understanding is that HRSA has actually been working from some of the recommendations of this report to work towards creating proposals for infrastructure. We also understand that there are other groups that are looking at putting together sort of evidence review infrastructure that could stand up and address some of that midterm evidence review infrastructure. One of them, who I probably shouldn't speak to, but I see Michelle on here, is ACMG, and there are other groups such as that that are looking at how they can fill that gap as entities that could provide some type of evidence review, but I can't speak for them, and I don't know whether those would yield recommendations or serve as conveners. But I'm heartened by the fact that we have so many leaders who are standing up to say, we will band together, we will work together, and we will see what can be done in the interim. And then in the long term or larger term, there are coalitions of organizations that have come together to ensure that the Newborn Screening Saves Lives Act legislation is reintroduced. That's actually happening right now, to make sure that there is a federal newborn screening infrastructure that moves forward. I think the overriding issue that I'll just speak to is that we have a resource issue, and we need to make sure that all of these things are resourced. And the devil will be in the details, because we need to come together as communities to inform what goes into all of that language. And we encourage everyone here, who obviously are informed stakeholders, to work together with all of us to make sure that those programs move forward. So that would be my perspective.
John, did you want to add to that? I saw your.
Well, Annie, did a really nice job of summarizing kind of where we are right now. I'll just say, and I have to, not speaking as a committee member now, but just from my own perspective, that we have a real void in leadership. And that all the different things that you described, ultimately, there's going to need to be some central federal leadership to help maximize things. But it's got to be leadership that owns the problem, that has the authority and the resources, as you mentioned, Annie, to help make things happen. Got to have committed and informed leadership to do it, a vision for what the future can do and needs to do, and then the commitment of partners to work together to make this all be a success. So, I think, work on getting the Newborn Screening Saves Lives Act reauthorized and the resources allocated and authority designated is going to be really an important component of that. But, the committee didn't make a specific recommendation about specific legislation, or saying, that Congress needs to do this or NIH needs to do that. We're really trying to say, here's what is needed at a programmatic level, and how that's going to be sorted out. Hopefully will be revealed soon, but it's going to take a lot of advocacy to make that happen.
The only other thing I would add to what you were saying, Don, about what is needed is really not just, this is my hat, me wearing my own hat now. It's not just a vision for what has happened in the past, but really a vision to
Right.
set us up for where the future is not just taking us, but is we are in the future.
For sure. Yeah.
On many
Future's
of these
here.
topics. Exactly. Great. I know we are at the top of the hour, but I have one more question for each of our speakers to quickly answer in about 30 or so seconds is, at the 1-year anniversary of this report, what do you hope to see will have happened? And it could be very, very feasible and practical, or it could be, a little bit more pie in the sky.
I don't mind going first because I really hope that we can see much more family engagement with the newborn screening system. I love that the report highlighted our role because it is our table as advocates, as parents who live and breathe these diseases. Like, this is our table too. And so I look forward to seeing more parent, patient, family involvement in the newborn screening system.
I would just like to add that I would like to see that the federal vision set up in order to continue the ongoing work of the states. I also add the part about each state stepping up and reviewing their current status and looking for what are their opportunities for ongoing excellence. But yes, I would like to see some establishment of the federal vision.
I'd like to see, I agree with all of those things. There's a lot we want to see happen, Natasha, but I'd like to see some tangible progress towards more coordinated research, because this is really the advocacy groups pushing so hard on things that feel so strong can be helpful, but then having the evidence to help support their requests has been and will continue to be essential. And so if we can have some beginning coordination across agencies to the extent that there is authority and resources to do that, to start answering some key questions, actually prioritizing what are the conditions and what are the research questions that need to be addressed quickly, and then to set up a network that those can be done in a nimble and targeted fashion would be great.
Yeah, I would just say that it is not possible to make Americans healthy unless we invest in healthy babies and our Americans from the very start. And so I think that this report provides a really beautiful roadmap for how we do that. And I would like to see this in the hands of every single policymaker.
Thank you so much to our speakers and panelists. Really appreciate your time and your thoughtfulness around this. As a reminder, we have 2 more webinars coming up, one on newborn screening as a high quality public health service for all. That will be Thursday, August 7th. And then preparing for the future of public health newborn screening, which will be the 3rd and final webinar in this series. And that will be Thursday, August 14th. Again, thank you so much to our presenters. Thank you to the National Academies for partnering with Genetic Alliance on this webinar series. And have a great afternoon, everyone.
Thank you.
Thank you.